Good morning. On behalf of Sri Lanka Medical Association, I would like to welcome you all to the first joint regional meeting organized by the SLMA in collaboration with National Dengue Control Unit, Ministry of Health, and National Institute of Infectious Diseases. Being true to our theme this year, excellence, equity, and community, we have focused on creating excellence in clinical care in dengue management, a disease of public health concern in Sri Lanka. So to start off the proceedings, I kindly invite you to rise for the national anthem. Thank you. Traditions are the backbone of our culture and our very existence. The traditional oil lamp symbolizes our quest towards knowledge as well as enlightenment. Therefore, I respectfully invite the following dignitaries to light the lamp of learning today. Dr. Vinya Ariratna, President, Sri Lanka Medical Association. Dr. Sudat Samaravira, Director, National Dengue Control Unit, Ministry of Health. Dr. Dinesh Koggalage, Director, National Institute of Infectious Diseases. Dr. Ananda Vijay Vikrama, Consultant Physician, National Institute of Infectious Diseases. Dr. Sajid Edilsingha, Secretary, Sri Lanka Medical Association. And Matron Vajira, Special Grade Nursing Officer. Dr. Lushan Jayasuri, sir, can you kindly come and enlighten the audience? Thank you, sir. Thank you, madam. Creating a nexus between the curative health and public health has been one of the key objectives of Sri Lanka Medical Association over the years. And this year, we are focusing especially on developing collaborations between the public health as well as clinical health. So I now cordially call upon Dr. Vinaya Ariratna, Consultant Community Physician, as well as the President of Sri Lanka Medical Association, to address you all and enlighten us about the objectives of this regional meeting. So over to you.
Thank you, Lairo. Good morning. Director of the National Dengue Control Unit, Dr. Sudat Samaravira, the Director of the National Institute of Infectious Diseases, Dr. Dinesh Kokkalage, our Senior Past President, Dr. Lushan Jayasuriya, Secretary SLMA, Senior Consultants, all the participants who are joining in person today for this important clinical seminar, the regional joint regional meeting, and also those of you who are joining online. I think we have more than 60 participants who are joining from around the country this regional clinical meeting. So I would like to firstly thank the National Director, National Institute of Infectious Diseases and the National Dengue Control Unit for collaborating with Sri Lanka Medical Association in conducting this first joint regional meeting. as Sri Lanka Medical Association, our mandate is twofold. One is to improve the knowledge and skills of doctors as well as allied health staff in matters related to national importance in the health sector, which of course includes clinical management and also prevention of specific diseases. As we all know, dengue is a very important public health issue in Sri Lanka, so we have to work both from a preventive perspective as well as curative perspective. So NIID has been at the forefront of infectious disease control in the country and has the mandate to also really disseminate the latest knowledge and also impart skills to the medical staff who are managing dengue patients. So secondly, our mandate is to really engage the public and also influence the policies on matters related to public health in Sri Lanka. So the SLMA series of joint clinical meetings or joint regional meetings are to bring together the best of experts in that particular field and also disseminate in that particular region. So we are starting with the Western Province, and we are very happy that we are able to have it at NIID with this particular topic as our subject of discussion today. We'll be following the joint regional meetings in other provinces as well for the rest of the year. So I would like to again thank Dr. Lahiru Pudituaku, who is Assistant Secretary of SLMA as well, who has been really working very hard to get this joint regional meeting organized today. So on behalf of the Sri Lanka Medical Association, again I would like to welcome all of you and also our senior consultants, resource persons who have joined us today to conduct this session. Thank you.
Thank you very much, sir. Now I cordially call upon Dr. Sudat Samaravira, Director, National Dengue Control Unit of Ministry of Health, to enlighten us about the objectives as well as the activities conducted from the National Dengue Control Unit in collaboration with SLMA and NIID. So, over to you.
Very good morning, Dr. Vitya Ratna, President, Sri Lanka Medical Association, and past President, Dr. Rushan Jayasuriya, and senior consultants of the NIID, as well as the Director, National Institute for Infectious Diseases, Dr. Dinesh Kulkarge, and all other participants online, virtually, as well as in person. This is one of the very good, very big event for National Dengue Control Unit in collaboration with the National Institute of Infectious Diseases and Sri Lanka Medical Association to disseminate this knowledge among the clinicians in the Sri Lanka, how to manage the dengue patients when they come to the hospitals. If you talk about dengue, when COVID struck us 3 years ago, dengue was the most important infectious disease in our country, with having very big morbidity and also with significant mortality. After controlling very well successfully COVID pandemic over the last 3 years, now again dengue has become the most important infectious disease in the country. So as clinicians, everybody is having a role and responsibility once a patient comes to the hospital to ensure that this patient will be well cared and will be sent back home without undue consequences as well as without mishaps like death. So I think as a national focal point for dengue control, we have joined with the National Institute of Infectious Diseases as well as with other stakeholders to ensure that the capacity of our clinical as well as the preventive healthcare staff will be adequately develop their capacity to do this prevention as well as the control activities, and also manage the patients very well. So we had a number of training sessions over the past year, especially after COVID pandemic, and I'm very much thankful to the senior clinical staff here, and also some other clinical clinicians that were joining from other hospitals for this training continuously, and we will be continually do that. In addition to that, National Dengue Control Unit is coordinating and ensure that vector control activities and also the vector surveillance activities will be carried out in the country, and also we ensure the community participation, social mobilization will be happening in dengue control, and also the other collaboration with the other stakeholders, non-health stakeholders will be ensured in the dengue control activities, because dengue control is not only a health issue, it is a social as well as the community effort that should be there. So with all these things, in addition to that, we ensure that the hospitals will be having adequate facilities to manage the dengue. So we hope that you will be getting the best out of this training session, this clinical session, how to manage dengue patients, and to reduce the morbidity as well as mortality in the country. So as the clinicians, not only taking care of the patient, they are having a dual role, and another role, that is the notification of the dengue patients as early as possible. So it is very much important to control the outbreak. So I think at the end of this session, everybody will get the knowledge to ensure that this will be happening. Thank you very much.
Thank you, sir. Now, to start off the formal proceedings, I would like to invite Dr. Vinya Arigatna, President, Sri Lanka Medical Association, Dr. Sudat Samaravira, Director, National Dengue Control Unit, Dr. Dinesh Kogalage, Director, National Institute of Infectious Diseases, and Dr. Nimalka Pandilhetty, Senior Consultant Community Physician, National Dengue Control Unit, to grace the head table. Thank you very much, sir, madam. Now, this entire regional workshop will be conducted under two phases. Now, in the first phase, we will be focusing on the epidemiology of dengue and the current dengue situation, as well as the clinical management of adult dengue patients. So, to chair the first session, I would like to invite Dr. Vinya Arigatna, President, Sri Lanka Medical Association, and Dr. Nimalka Pandilhetty, Senior Consultant Community Physician of National Dengue Control Unit. They will be introducing you the speakers as well as the objectives of the session.
Thank you, Lahiro. The session that we are going to have today, we have the first session we are going to have today. We have Dr. Jagat Amarasekara and Dr. Ananda Vijayvikrama as resource persons. So the first will be Dr. Jagat Amarasekara, current country. He will be speaking to us on the current country situation and the notification of dengue. I invite Dr. Nimalka to introduce the speakers and then chair this session. Thank you.
Thank you, Dr. Vinay. Among the galaxy of speakers today, I would like to introduce the first speaker, Dr. Jagat Amarasekara, Consultant Community Physician. After his illustrious career in the epidemiology unit, he has worked in anti-malaria campaign, and we are privileged to have him today with us. in the National Dengue Control Unit. He'll be speaking today on current dengue situation in Sri Lanka and also notification system, which is vital for establishing surveillance in Sri Lanka for dengue. I am pleased to invite Dr. Jagath Amarsekara to make his presentation.
Thank you, Nimalka. So, thank you for the introduction as well as for inviting me for this session. And as requested, today I'll be discussing about the current dengue update and a little bit about the surveillance system that is present for the dengue surveillance. So, before we start about the update and the disease surveillance, just some key facts so that we can initiate these discussions. So as we know, it's caused by a virus which has 4 serotypes and transmitted through a mosquito, infected mosquito of the Aedes aegypti and Aedes albopictus. So another important thing here is that there is about 100 to 400 million infections occur annually, although 80% is mild and asymptomatic. So just to give a rough idea of the global burden also. So we have people at risk 3.9 billion, and out of that another key point is that over about 36,000 deaths. So the global burden is estimated at about 36,000 deaths annually. So we are talking about a disease of great public health importance globally as well as in Sri Lanka. So this is just the trends of the dengue patients and the case fatality rate from 2001 to 2022. So these are the latest updates. And if you look carefully, you will see that from 2001 to about 2008, that you have some sort of a disease incidence about 10,000 or less. So this is like the picture that we saw earlier, but after 2009 onwards, we have about 35,000, 40,000, 50,000, that sort of a picture. So that's the situation in Sri Lanka. And we have basically a big outbreak in 2017, 186,101 cases, as well as in 2019, 105,000 cases. So we have that sort of a picture here. And if you look at that and then compare that with the case fatality rate, that is also an important area, that you might see that in the beginning, now even if you look at 2009, you have 35,000 cases with a case fatality of 1%. So if you have 35,000 cases and 1% case fatality, you are going to get 350 deaths. So if you apply that same case fatality to 2017, you might get about 1,860 deaths. So the contribution of the clinical management and how it has evolved has contributed to reducing the deaths also. From that about 1% cases, we have reduced, now currently it's about 0.1%. So all these preventive sector, curative sector, how that we have to reduce the cases as well as deaths. So everything complements and it goes hand in hand. And if you look at our objectives, outcome objectives of the National Dengue Control Unit, there also you can see that in 2020, 21, 22. Now 2020, 21, if we go to the next slides, I can show that we had a lower incidence compared to the other years. Still our case incidence has to be kept 100 per 100,000. That means for 22 million population, we have to keep it at about 22,000. So that is I don't know how realistic that we can achieve that. So in 2022 also 346 per 100,000 population, when our we have to keep it at 100 per 100,000. So it's very much higher than what we want. But the deaths, we have kept it below the 0.1% throughout. So this is the basically when you look at the national objectives of the National Dengue Control Unit. I think, okay, it's okay. So basically, if you look at the trends, right? If you look at the trends also, this is something that we have to watch carefully. Now, if you look at the trends, and from January to December, in these 3 years, another important feature is it is linked with the rains, right? It's linked with the rains. So we have the southwest monsoon and the northeast monsoons that contribute, followed by which we have the peaks. So as you can see in 2022, it's very well evident that we have got the peaks contributed by these monsoon rains. But if you look at like 2020, March onwards, if you go to 2021 October, irrespective of the weather, irrespective of the other issues, it has been constantly flat. So that is actually attributed to the COVID pandemic time. We had less cases. So that is an important finding, not only in Sri Lanka, globally also. There are a lot of people have now. Always we look at these figures with a temporal sort of a way, with the figures and the rain and all that. But spatial distribution as well as other factors that affect also is important. Now, I have read a few journal articles globally as well as in Sri Lanka. What they say is the disease, the decrease of dengue cannot be attributed to the temporal or any other factors, disease burden or anything, the vector disease, other than the restriction of mobility during that period. So maybe in a way forward, we have to look at other factors also that will be important for the dengue. Basically the dengue incidence. And another thing is that during that time, during COVID, people were at home. So when they don't go to school or any other workplace, the virus doesn't travel to that area. So even if the vector mosquito was there in both places, the transmission is less. Second thing is they kept their premises clean because they were always at home. So those things contributed. Even under-reporting and all those factors cannot correlate compared to this. These are the reportings of the dengue cases 21 to 23, and now we are also actually, it's a very timely thing that we are having this session, the joint meeting, because now it's let's say up to 20th of January, right? 20th of January this year we have 5,600. So I think currently, although it's around 7,000-8,000, so we are having a peak compared to 2022 January. So we are at an upward trend. So having this kind of timely meetings and imparting with the clinical management is of great importance. This is the burden of the disease by different areas. Now, this is also another aspect that we have to consider. For example, if you look at the current cases in 2022, if you look at Colombo MC and RDHS Colombo, Gampaha and Kaluta, that is the western province, it has contributed to about 45% of the burden of the disease in Sri Lanka. So when you are looking at that, it is very obvious that when we do key strategies and all that, we have to focus on the high-risk strategy, how important that information is. So in addition, we have Kandy, Putlam, the Ratnapura, Gaul, Jaffna, those districts also have contributed greatly to the burden. So we have basically about 76,000 cases and the distribution of those cases by different districts. So if you look at the population and the incidence also, Colombo, Gampha, Kalutara, those have a higher incidence by the population base, but Jaffna also is high in that sense. So, but although those are in different districts, what is important is the peaks occur at different times sometimes, because northeast monsoon might attribute to high case loads in Jaffna and the east side, especially now we are having high incidence in Kalmune also. So while the other rains and as well as the northeast might give rise in the western province. This is also a key fact about the age distribution of dengue cases. So that also shows the basic, the median or the mode and the mean, everything corresponds to the middle age groups. So when you have the contributions from, let's say, 20 to 50, so what is important is, in knowing this contribution, is that we are having this age group. So when we have the middle age group, another issue with the fever surveillance is that they might not come on time because they are doing jobs, they are looking after the children, so they might have delayed implications. So that is also something that clinicians and the curative sector has to keep in mind when you have this kind of age group having high incidence. So they might come when they have to go, so they won't come. In addition to giving the messages, they might get delayed admissions as well. So these are the deaths. We have had 72 deaths, and as seen with the incidence, so the incidence in Western Province and the deaths and those also correlate. So 72 deaths in 2022, and the breakdown of these deaths also is corresponding to the age structure of the cases. So there's not much difference in that. Here the female 56 and the male 43, the contribution. So, but we are talking of a small number, so these percentages vary with 1 or 2 deaths difference. This is another area, the serotype of dengue virus studies in 2021 and 22. So I won't, basically we can't actually look at this and say for Sri Lanka this is the virus that is spreading, because the numbers that we have done is 272 in 2022 and 434 in 2021, and most of the time when we take these samples, and it's done at MRI, Teaching Hospital Kandy Virology Lab and Center for Dengue Research, University of Sri Javadhanapura. So I take this opportunity to thank the virologists and the staff there for doing this. But we take these when there is an outbreak in certain areas or some incidents where the reporting of cases may be different from the usual reporting. So this pattern has come. So basically, dengue virus 2 and 3 is the one predominant, but this is taken from those samples. So we can't really tell this is the spread in the entire country because of this fact. But these are the two types that have been spreading in the last couple of years, dengue 2 and 3. Okay, as mentioned, a little bit about the integrated disease surveillance of the epidemiology unit. This is the notifiable disease surveillance system. So I'm not going into this complex sort of a diagram, but just to recap, what we do is when the clinician suspects dengue, so the keyword is suspect dengue, it is notified. So this is the paper-based one where it's entered in the 544 notification form, and then it is sent to the area of residence of the patient, the MOH. The MOH then gives to the SPHI and PHI, and the PHI goes to the field. PHI goes to the field and goes to that house. So what does he do? So basically when he goes to that field, first thing is he confirms the diagnosis. Confirms in the sense what he does is, maybe the suspicion was dengue, but later on it became like clinician on suspicion immediately maybe thought of the exposure everything and thought it's, when you're managing, it was left out. So it can be the other way also. So the PHI will look at it because the preventive strategies change. So that is what you mean by confirming the diagnosis. Based on how the diagnosis, whether it's the same, but it is not a problem. Most of the time, if it's dengue, the diagnosis at suspicion, confirmation also, dengue, then what else does he do? He will see the other people in the house and the people around for fever symptoms and tell them to go to the hospitals for treatment. So he will motivate them to go there. In addition, what else does he do? The PHI. PHI will, if now, for dengue it might not be the case, but other diseases, the PHI might tell them, if they, because we have a tendency, if we get fever, if we are cured, if you are supposed to go to the clinic in 1 month or 2 months, this is not for dengue, maybe for other diseases, it might be applicable. He might have to motivate that person to go continuously. And then the other thing is, with the community in the area, do some strategies to prevent the further spread of the cases. So at PHI level, that happens. Then the statistics of his reporting will go to the MOH. And when that MOH level, they will also use that for resource distribution, capacity building, which areas are high risk. That will transfer to the district level as well as national level. We can see which areas are getting outbreaks, so all this happens because of the notification from the hospital. So, the clinical staff, when they manage dengue, in addition, it is very crucial for the notification. And notification has to be on suspicion, not waiting for confirmation, because one of the key things is to immediately act and reduce or prevent outbreaks in that areas, and also take that for further action. So this is the usual one. So DENSIS system, that is with the epidemiology unit and the National Dengue Control Unit. So that what happens is, without waiting for paper-based, immediately in the evening, in 100 and basically this is the system that is there. It's the same notifications made quicker through this system as well. So it's a complementing thing for the routine notification system. In 151 institutions at the moment, online update is done by the ICNO to the relevant MOH. So if the patient got admitted today, in the evening, the notification details are available with the MOH. MOH will give it to the, area PHI. So that is within 24. So it helps to be active, proactive in the sense, and it is accessed at different levels. So this is the DENSIS. So it is coming on timely. Then we have another surveillance system, just to recap, it's called a midnight total. That is not the individual patients, but the absolute numbers present in the hospital on that day. Let's say there's 20 patients. Then the ICNO will give that number. That is done for 75 government hospitals. So, so let's say you can see the trend in the hospital, whether it's increasing. So this is a good, basically, way of assessing whether we have to improve the, maybe if the patients are coming, the rate of the midnight total is like, today it's 10 patients, tomorrow 15, 20. If it's going up like that, then the hospital itself have to strategize and see whether you'll have to have a referral, you'll have to have different mechanisms to cope up with this, whether you have to utilize and give the resources. So many things can be taken from the midnight total. So midnight total depends on two things: the admissions as well as the duration of stay of the patient. So that absolute number helps us also as the National Dengue Control Unit when we are doing clinical trainings, when we have to give, when we have development of infrastructure, facilities, we see the midnight total or the burden of the disease in the hospital. So these are the two areas, and how crucial the clinical on suspicion that it is notified. Another small thing about notification that I want to tell is, like, sometimes there are people who are from rural areas, but their place of residence is rural. So actually the notification says to inform the place of residence. So not the places they visit and all that, but still if they are in construction, let's say in Colombo, and last 2-3 months they are in Colombo, maybe that would be the more preferred place to notify, because basically although their residence is there, they are staying for 2-3 months here, and maybe they would have got the infection. So that also is something that you, clinically you have to, when you're notifying, you have to take into consideration. So those are the basic things about the surveillance system. And we have a feedback from the National Dengue Control Unit, the monthly dengue update as well as the weekly update. If you look at it, in addition to the feature articles, we have in the monthly one, entomology and the disease surveillance and viral studies and viral reports and all that. But weekly one, basically every week we have the update. It says the number of cases by the districts, as well as the high MOH areas, few MOH areas which are showing the increase, and the average midnight total for certain hospitals where it's increasing or where the burden is high. So when you can log into the National Dengue Control Unit and see these things also, and then get an idea of the situation, because we disseminate and give feedback for all these in a very timely manner, so that everyone can utilize this data for action at all the levels, hospital, MOH, district, and the national level. So this is just to recap, and thank you very much for the opportunity. So I will step down now. Thank you very much.
Thank you very much, Dr. Jagath Amarasegara, for your informative presentation based on the surveillance data sent by the curative sector, which we use as public health specialists for preventive activities. Next, I would like to introduce the second speaker. With deep pride and humility, I would like to introduce Dr. Anand Vijayvikrama, who is one of the past presidents of the College of Physicians Sri Lanka and President-elect SLMA. Inspired by his deep passion for teaching and training with his eminent team, he will enlighten us on management of dengue fever and dengue hemorrhagic fever among adults. Let me invite Dr. Anand Vijayvikrama for his presentation.
Good morning. Thank you very much for giving this opportunity. I think it is important, as we all know, dengue is prevalent in our country. The present situation is that, as pointed out by Dr. Jagath Amarasegara, you know, dengue is endemic in Sri Lanka, and cases are reported from all over Sri Lanka, with more than 40 to 50,000 cases reported every year. And we know there are two peak incidences related to monsoon rains, but cases are reported throughout the year, which is important. Therefore, if we get a febrile patient, dengue should be considered in the differential diagnosis. And also, more importantly, if a patient presents in shock, dengue shock syndrome should be considered in the differential diagnosis. Of course, there are several reasons for a patient who presents in shock, and do not forget the possibility of dengue shock if you get a patient to the emergency in a shock state. More than 70% of patients at the moment are above 15 years of age, and more than 50% of patients are between 15 to 45 years of age, which means the workforce of the country has got affected, is getting affected. And also complications are higher in adults more than in children, because especially because of their associated comorbidities. And also pregnant mothers also tend to get affected because of the affected age group, and complications are more common in pregnant mothers compared to other populations. And therefore the death rate is also seems to be higher than in children in adults. As shown by earlier, the incidence is like this. In at 2009 we had the first big outbreak with 35,000 cases, and then in 2017 we had a very large outbreak of 186,000 cases, and since then we have been having more than 50,000 cases per year. However, in spite of that, the death rate, which was 1% in 2009, had come down to less than 0.2%, or rather 0.1% by 2019. So how did we reduce this mortality in dengue? We were able to have better understanding of the pathophysiology, and then many of our clinicians had the opportunity of getting trained in Thailand, where they have a lot of experience in managing dengue. And since after that, we changed our treatment guidelines and trained our health staff, and with that we started to have better monitoring and identification of crucial situations which warranted prompt action. However, still 0.1 to 0.2% of patients die, and some of them, or majority of them probably, can be saved. So why do these patients die? Some people have severe plasma leakage, and that lead to reduced intravascular volume, and they go into shock. Some have severe bleeding, again reduce intravascular volume and go into shock. And many patients have plasma leakage and bleeding together, resulting reduced intravascular volume, going into shock. And especially most DHF patients who go into shock, tend to bleed. If shock is prolonged, they go into liver failure, disseminated intravascular coagulation, and bleeding, and they can die. And if shock is prolonged without treatment for more than 6 to 8 hours, they go into multi-organ failure. This is a slide which was shown to us in Thailand, which I believe is still true. If a patient in shock is untreated for 10 hours, whatever we do after that, they die. If they are untreated for 4 hours, they can go into liver failure, where survival is only 50%. And if it is liver and renal failure, survival is said to be only 10%. And 3-organ failure, they said survival is a miracle. Which means that we have to detect and treat the patient in shock as early as possible. Otherwise, they can develop this complication which can lead to death. So during the last, about 10 years ago, 12 years ago, there were significant changes to our clinical practice management. We changed the case definition of suspected dengue. Regular full blood counts in a fever patient is recommended, and early identification of plasma leakage and bleeding is done by regular hemodynamic and urine output monitoring, using hematocrit monitoring, and using focused ultrasound examination. Now these are major changes which were done to the management of our patient. This little gadget is now available in most of our wards, which is a very useful, or rather essential instrument for the management of dengue patients. It gives quick results, which results are reproducible. If you think the result is wrong, you can do it again. It's low cost, it costs very little, and you can always do it in a short period and get the results then and there. and a lot of our nurses do this, which is very important in the management of these patients, because in in decision making, together with the hematocrit and the hemodynamic parameter changes, we have to decide what to give to these patients. And in addition, there were many other changes in the management, manipulating of fluid quota during the critical period, giving dextran later in the critical phase, blood transfusion when bleeding is suspected. And unlike in the past, where we were doing giving a lot of platelet transfusions prophylactically, we do not give platelet transfusions now, and there's no place for steroids. 12 years ago, we used to give platelet because we thought low platelet was the problem. But now we know it is not the problem, and especially it is not the reason for the bleeding. Therefore, we don't give prophylactic platelet transfusions. But still, we have problems. Some patients still come late to hospitals, maybe various reasons, due to social reasons. Sometimes doctors don't advise them properly to go to hospitals in spite of having low blood counts. And sometimes when some patients come late in spite of having low blood counts and sought medical advice where they were not asked to get admitted. We are surprised. I don't know why some doctors take that risk. And also it is unfortunate to see that still some doctors and maybe quacks are giving steroids and NSAIDs to these patients who come with fever to reduce their symptoms. And a lot of these patients tend to develop complications. And we know there are delays in getting full blood count reports. As many of these dengue patients won't have problems, only about 20% or less than that, or 15% develop plasma leakage. And out of that also, another small percentage goes into shock. So a lot of people recover without anything. Therefore, sometimes doctors seem to be, especially in the general practice, seem to be overconfident and not advising patients to get admitted timely. And also another reason for late admissions is this negative dengue test. We know dengue antigen test is a good test, but it's not 100% sensitive. So the negative test does not exclude dengue. That is important to remember. And then there are problems in the management too. Sometimes dengue is not considered in the differential diagnosis. Sometimes dengue was thought of, but the patient was not monitored. On-site hematocrit was not done. Sometimes the leaking was not identified. Critical phase timing was not correct. Fluid was given at a flat rate in spite of patients having leaking. Fluid boluses were given instead of increasing fluid gradually. For example, when the urine output goes down, the boluses are given, and blood was not given or late, and dextran was given too early sometimes. And the patients are monitored sometimes very well by nurses. Problems are detected, but sometimes we see doctors have not taken appropriate actions. And these are the problems which we have to address and correct. Let's look at a couple of case histories to see what happened. This 17-year-old girl was admitted to a suburb hospital in Colombo, admitted in an evening. This happened about 5 years ago, fever and headache for 3 days. So symptoms suggestive of dengue. And so they suspected dengue and they sent full blood count and dengue antigen. Patient was afebrile on admission, which means the patient can be leaking. If a dengue patient is afebrile, you have to suspect the possible leaking at that time. So the full blood count and antigen had been sent. And next day morning, she was found to be in shock. And the full blood count done on admission showed platelet count of 70,000. PCV was 40,000. Another blood count had been sent in the morning where PC was 40 and platelet was 44,000. Ultrasound shows leaking. Unfortunately, the full blood count done on admission was seen in the morning only. So the patient was not monitored overnight. And patient had been in shock for hours. And then the patient was given a fluid bolus, and then the patient was sent for ultrasound scan, which was during which period she was not having fluid, and then the fluid was cut down very rapidly. And when you note, this patient had no change in the hematocrit compared to the first one and the hematocrit at shock or PCV at shock. There's no change, which means in addition to plasma leakage, patient had bleeding. However, this was not properly realized and patient was not given blood early. So the other patient was in shock without a PCV rise, which means the patient had bleeding. So, and the fluid was reduced very quickly rather than reducing it gradually, which means the patient is not getting adequate amount of fluid to refill the intravascular compartment. And blood was late. And next day morning, patient was very dyspneic, tachycardic, and later patient was transferred to us, but we couldn't do anything by that time, and this 17-year-old girl died. So even though the dengue was suspected, full blood count was ordered, intake output was measured, but shock was identified only the morning. Blood was given, but that was too late. So even though patient was afebrile, when a patient comes in afebrile state, you have to suspect possible leaking and start monitoring this patient even if there is no blood count. But of course, getting the blood count early is very important. And the critical phase, when a patient is found to be in shock, we think the patient is in the middle of the critical phase, not at 12 hours. And blood has to be given if there is evidence of bleeding. Don't wait to see blood. Don't wait to have visible bleeding. Patient, they bleed internally, and most of the time bleeding is occult. This 14-year-old boy admitted with a history of fever for 4 days. These are true cases. Weight was 32 kilos and PCV was 44 when the platelet count was 131. These clinical features are enough to diagnose clinical diagnosis of dengue. And patient was monitored, and when the output went down, instead of increasing the fluid, patient was given boluses of 500 ml over 1 hour. Patient's weight was 29 kilos. Now this 500 ml is for a 50 kilo or more person. So when you give this sort of boluses, patient becomes overloaded. So the patient was, diagnosis of dengue was made, but for a 32 kilo patient, this is the amount was too much. And ultrasound shows leaking. And again, you can see intermittently boluses are given. So it is important that it was suspected, the leaking was suspected, saline was given, but calculation of fluid quota for a child of less than 50 kilos is important. And if you give more fluid during leaking, too much of fluid during leaking, the leaking will be more. If you give too little fluid, then patient will go into shock. So by end of 12 hours, patient had much more than half of the required quota of fluid. And then the fluid was cut down, another bolus was given, right? And next day morning, patient was found to be unstable and dyspneic. So he was sent here, patient was obviously overloaded, patient was given 4,500 ml of fluid by that time. So later we treated patients with dextran and later furosemide, then of course the patient recovered, fortunately. Patient lucky to recover. This is another case which was presented by a registrar of a medical unit of a teaching hospital. She was this girl again, a 17-year-old girl, admitted to a preliminary care unit with fever for 2 days. So they have suspected dengue, but she was dengue antigen was positive. It was done and it was positive. And next day morning she was continued to have bleeding PV. And then on 4th day she had tachycardia. She was complaining of chest pain. An ECG was done, which shows T inversions in all leads. And because of these T inversions, they suspected possible myocarditis and restricted fluid. Restricted fluid to 50 ml power. Usual maintenance dose is the 100 ml power. So it was given less than that. In spite of having unstable hemodynamics, the heart rate was 130, which is quite high and which indicates some significant problem. And then the patient continued to have fever. Now there's postural blood pressure dropped, and they did an echo which showed pericardial effusion. Ultrasound shows pleural effusion, ascites 3+, so there was a lot of leaking. However, because of these T inversions and pericardial effusion with the suspicion of myocarditis, there's further reduced fluid. Now this is a patient who is leaking, whose intravascular compartment is getting decreased, but because of this suspicion of myocarditis, fluid was restricted to less than the maintenance dose even. And next day, the patient collapsed and died. The same day night. And unfortunately, they did a postmortem, and postmortem did not show any evidence of myocarditis. Now, even though if there is myocarditis, we have to maintain the intravascular compartment in these patients. That is the most important thing. In dengue patients with leaking or bleeding or both, we have to maintain the intravascular compartment. If the intravascular compartment intravascular volume is not maintained, the liver perfusion gets impaired, they will go into liver failure and they can die of that. So it is very important. When they are leaking, if you see leaking, you have to increase the fluid to keep the intravascular compartment adequately filled. So whether the patient is having myocarditis or not, that is irrespective of that, we have to maintain the intravascular compartment. So we cannot restrict fluid during leaking. Of course, during the latter part of critical phase, we restrict fluid. And also suspect bleeding in patients who have tachycardia, or hypotension, or both, or peripheral shutdown, prolonged CRFT, with no rise in the PCB or reduction of PCB. Suspect bleeding, they are likely to need blood. This another case is represented by a SH of a medical unit. Again, a small boy, 13-year-old boy, admitted with 1-day fever, 29 kilos. Patient was blood platelet count on admission was 206,000, and the same day patient had fever. This is the temperature chart. The fever settled on day 3, mid day 3. Now, in a dengue patient, when fever settles, you have to anticipate leaking. That's the more likely period of leaking if they develop leaking. Of course, they can leak when the fever is there, but if you have to suspect more or look for leaking when the fever is settling. So you can see these patients, the fever settled around day 3, and in the morning he had high fever spikes, but afternoon you saw the chart, it was settling, and patient was started on antibiotic because of respiratory system. Now, the platelet count is going down on day 3. Morning, platelet 128, afternoon 103, PCV is around 40. Now, the leaking tend to happen generally when the platelet count goes below 100,000, especially in children. In adults, it can be later when the counts are much lower, but you have to look for leaking again when the platelet count goes below 100. ST was a little high, antigen was positive, and so the patient was monitored. Maintenance fluid was given, 60 ml per hour, and next day morning, the fever, of course, has settled. These are the slides I haven't changed. They are same as presented by the SH of this unit. Blood pressure 100/70, and they continue the dengue fever monitoring. And at 11 o'clock, they get the blood count done in the morning, which showed platelet count of 41,000, and the PCV of 52. Now the liver enzymes have started to go up. Now the PCV baseline was around 40. Now it is 52, which means there's a rise of 30% in the PCV. If the PCV rise is 20% or more, that indicates definitely plasma leakage. When it is 52, that is 30% rise. In a patient who had a baseline of 40, that means there's severe plasma leakage, which means their intravascular compartment is getting diminished. In turn, their liver perfusion will get diminished. So this patient, they calculated the fluid quota. For some reason, they divided it by 48 hours and decided to give 60 to 65 ml per hour, even though the patient had leaking, or even though the patient had significant PCV rise. Urine output goes down, patient becomes tachycardic. Now if you remember the fever chart, by this time the patient is afebrile. Patient is getting right hypochondrial tenderness. If a dengue patient is complaining of right hypochondrial tenderness toward the latter or around day 3-4, always suspect the possibility of leaking. And look for leaking and bleeding too. Now we see the counts done during the day. 3 times it was done thrice. Morning PCV platelet 41, further reduces, goes down to 13,000 by 5 p.m. PCV 52, then 57. And that is the 40% rise in the PCV, which means patient has leaked significant, very heavy leaking. Right? Which means again the intravascular compartment is getting diminished. Liver perfusion is getting diminished. And you can see the AST level, which was 212 in the morning, has gone up to 1200 by evening, reflecting the liver damage. Of course, the AST rises late. So when you see the liver enzyme AST of 1000, that means the liver damage would have started about maybe 18-24 hours before. And unfortunately, the patient was continued on same maintenance dose of fluid. You can see the SHO in the slide making has said patient was connected to monitor. And next day, the fever is settling, actually no fever by that time. Blood pressure is now going down, patient is getting tachycardic. Ultrasound was arranged. Yeah. And they mentioned keep connected to monitor. Next day morning, PCV is 58. Now the liver enzymes have gone to 5300 AST, showing very high liver damage. Ultrasound shows plasma leakage, effusion, ascites, and then because of these complications, patient was transferred to a close by teaching hospital. And this, by the time of transfer, patient was tachycardic, pressure was 90/60, and had right hypochondrial tenderness. And these slides shows how the parameters change. On day 2, on admission, patient was stable. Next day morning, the next day patient was stable. Now you will remember the fever settled on day 3 and the platelet count went down here, crossing 100 mark, and patient is now becoming tachycardic. Blood pressure, pulse pressure remains 30. So these nice slides shows very clearly what happened to the patient. It is here the fever settled. It is here the platelet crosses 100,000. These are 103 here. And PCV has started to rise. Patient is leaking now. And the liver enzymes is going up now because patient had underfilled intravascular compartment. This was presented at the dengue mortality conference, and the consultant who accepted the patient at the teaching hospital also was there, and he said by the time the patient came there, which was about 15 or 20 kilometers away from the base hospital, the patient was in full-blown shock. And they tried their best, and they couldn't save the patient died. So the simple reason, you can see how nicely the monitoring was done in this patient. And how I think the SHO who did the presentation probably knew what happened to make so nice slides, and so representative slides. However, there was no action taken for the PCV rise. It was completely ignored. There was no action taken for the tachycardia, which happened without fever. So it is important to detect these parameters, changes in these parameters, and take action. It is important to measure PCV, and if there's a change, interpret it with the hemodynamic parameters and take necessary action. And it is with that we can save this sort of patients. This 13-year-old boy should not have died. Patient came early on day 2 of fever, leaking parameters monitored well. One thing I would like to take your attention to is the fact that in spite of all this, the pulse pressure had been remaining around 30, which is, I would have thought that it is not correct. But looking at the slides, the way the slides was made, I don't think the doctor has put bogus figures here. I think there's a lady doctor who presented the case. I think she had made the correct slides. So I was wondering what is the possible reason. And when I discussed this with the pediatrician said sometimes the children tend to maintain their pressures till the last moment. Maybe that, or maybe, I don't know whether this was done deliberately by this doctor. If you see now, in 2 places in the slides, they are mentioned the patient was connected to monitor. Again, patient keep connected to monitor, which we don't put in the slides. So probably, in my opinion, what probably happened was they were measuring the blood pressure with the monitor only. And the monitor, it may be the monitor reading which showed the blood pressure of 30. When the pressures are low, blood pressures are low, the monitors sometimes do not give correct reading. So it is important, it's okay to use these monitors and other gadgets, but it is important to physically examine the patient. It's important to touch the patient. When you when you check for pulse, think about the pulse volume. Think about whether the extremities are clammy and cold. If those are there, that means there is a problem. So it is important, especially in patients who have problems, complications, to check their blood pressures, their pulse volume, their pulse rate, volume manually. Don't entirely depend on monitors. You can use, but don't entirely depend on those. So I think if these things can be done, if they can be monitored, and we see many patients who, in many instances where actions are not taken appropriately because of the lack of PCV. Because in some hospitals, in some wards, the PCV is not done on site. They depend on the PCV or the blood count, which you get in 6-7 hours later after the count was sent to the lab. I think if there is no hematocrit machine in the ward, or if you do not have access to a hematocrit machine where you can get the hematocrit within 10-15 minutes, you can't manage dengue patients in that ward. So either get a hematocrit machine or transfer those patients to other hospitals. And hematocrit machine is not expensive. It's a cheaper one, and even the measurements are also not expensive. I think if these sort of changes can be done, I think we can further improve our management and reduce our mortality rate further. Thank you.
you very much, Dr. Anand, for sharing your vast experience to improve clinical management of dengue patients, having analyzed all the drawbacks so meticulously to reduce case fatal rate among the patients.
Thank you very much, sir. Thank you, madam. Thank you, sir. And now we will break for the morning refreshments. For the physical participants, refreshments will be available at the cafeteria just beside this room. And for the online participants, we will be meeting you all again at sharp 10:30 a.m. Thank you very much.
ඊළඟට මගේ ප්‍රසන්ටේෂන් එක කොහේ හරි තිබුණේ මේකද ඉස්සරහට කාර්යය කරන්නේ
Walking come. Oh, එතකොට වෙන වැඩි එක අනිත් එක Wi-Fi hotspot එකකින් කහුවද? යා පුළුවන් නෝ ඒකින් කරන්න ඕනේ. ඔය වෙලා යනවා වෙලා කියන්නේ. නෑ නෑ තාම
මම කියන්නේ
උසක තියන්න
check one. Check one. Check one. Check 1, 2, 1, 1.
Oh, එතකොට හරි.
Check 1, 1, 2.
Welcome back. Now we will begin the second session of this joint regional meeting. To chair the proceedings, I cordially invite Dr. Anoja Devrasinghe, Consultant Community Physician, National Dengue Control Unit, to grace the body.
Thank you, Bahiru. Our next speaker is Dr. Damayanti Dampitiya. Dr. Damayanti Dampitiya is a consultant physician at National Institute for Infectious Diseases. And as a key member of the clinical team of NIID, she has rendered a distinguished service during both dengue and COVID-19 epidemic in Sri Lanka. She's a master trainer in dengue clinical management, involving numerous training and research in dengue clinical management. Over to Dr. Damayanti and her team, Dr. Susantha Asiri, and he's a consultant physician, and Dr. Thisara Perera, consultant physician, to conduct next interactive session.
Good morning. Thank you, Madam, for your kind words of introduction. So, in this session, what we thought, we will be giving you some questions with regard to dengue management. So, it will be via a Kahoot web-based platform. and we'll be sending you 16 questions. So after you answer the questions, we will have the discussion. So I invite Dr. Tisara Pereira, our consultant physician, to describe how to log on.
Good morning. So this will be a interactive session where you have to use your phone. So if you have your Android or Apple phone, both the platforms can join to this Kahoot game platform. What you have to do is just enter www.kahoot.it in your web browser, and then you will be led to the web page. It's shown on the screen as well. So what you have to do is enter the game pin, and after that they will ask for a nickname. Enter a nickname which you can identify. So we can go up to 400 participants. After that this will be locked. Since there are a few participants still joining in, we will wait for another maybe two minutes. Since there are no new members joining in, shall we start? So there will be 16 questions, and each question has different time duration. So for the first question, we have given you 90 seconds. So we'll start with the first question. Yeah, so this is a best of 4. So you have to select the best out of the 4 options that is given.
So we are going to start the questions now.
You can see the questions in your phone as well. You can see on the screen.
So 134 correct answers we have got. So we'll move on to the second question. Correct answer. So, okay, we'll move on to the second question. The correct answer is plasma leakage. So we have got 134 correct answers for this question as well. Good 109 correct answers this time. We'll move on to the next question. Again, 124 correct answers. We'll move on to the fifth question, number 5. This time 85 correct answers. The correct answer is the first one. So 98 people have got it correct. We'll move on to the question number 7. The correct answer is the first one. We'll move on to the next case. Okay, first answer is the correct one. Next question number 9.
So we are going to the next question. If you are not sure about the answer, just choose any of the answers, because if you all answer it before the 4 minutes time period, we can go to the next question. So others would not be need not to be waiting. Thank you.
Okay, first answer is the correct one. We'll move on to the next question.
This chart, if you can't see, you can enlarge on your phone.
So in this, according to this graph, two normal saline boluses and a dextran given, taken like 24 hours to the critical phase at 5 o'clock in the morning. So 5 to 6 1-point bolus, 6 to 7 1-point bolus, 7 to 8 dextran bolus. So we are asking what are you going to do at 8 o'clock? 85 correct answers. We'll move on to the next question. First answer is the correct one. Next question number 13. 12. 13. 79 people got the answer correct. Next question is question number 14. Ninety-eight correct answers. We'll move on to the next question. Okay, next question is the last one. Okay, we have finished the questions. Hope you all enjoyed. Now we'll discuss the answers briefly.
Somebody by the name of UK has won the quiz.
So congratulations, Subeka, for the first in the quiz program. Okay, we'll move on to the questions. First question is the majority of the dengue patients will have DF, DHF, dengue shock or DF with unusual manifestations. So, like if you take the number of patients who get dengue, the dengue infection, majority will be asymptomatic. Out of the symptomatic people, again around half of them will be like undifferentiated febrile illness. We don't diagnose them as dengue. So out of the people who we diagnose as dengue, majority will be DF and DHF will be around 1/5 of the amount of DF. Unusual manifestations are very rare, and dengue shock syndrome will be only 1 to 2%. So the correct answer is dengue fever, first one. The question number 2, what is the difference between DF and DHF? Bleeding, thrombocytopenia, plasma leakage, and high fever. So when we consider DF and DHF, it's clinically similar in the first few days. Both groups have high fever and bleeding manifestations, thrombocytopenia, leukopenia common to both groups. So only difference is the plasma leakage in DHF. So the correct answer is the number 3, plasma leakage. Third question based on the high risk factors for complicated or severe dengue. So 33-year-old obese pregnant lady with past history of dengue fever. 16-year-old previously healthy boy with a body weight of 40 kg. 80-year-old patient with well-controlled diabetes and ischemic heart disease. Otherwise healthy 26-year-old lady who has undergone mechanical mitral valve replacement 3 years ago. So out of these, which patient cannot be categorized as a high-risk patient? So when we take the risk factors, secondary infection, that means the first, when somebody gets dengue for the first time, is going to be a mild infection, but the secondary infection will be severe. And elderly people more than 70 years of age, children, small children less than 1 year, they tend to get severe or complicated dengue. People who are having chronic diseases like diabetes, ischemic heart disease, bronchial asthma, and the patients who are on antiplatelets and anticoagulants tend to get severe dengue. And pregnant and obese people are more prone to get severe dengue. So when we consider our answers, 33-year-old obese pregnant, so the patient has 2 risk factors, so that, and in addition she has a past history of dengue fever, so 3 risk factors, so she's definitely going to be a high risk person. 80-year-old patient, that's elderly person who is having diabetes and ischemic heart disease, so chronic illnesses, and in addition, as the patient is having ischemic heart disease, patient may be on aspirin, clopidogrel, so that patient is also high risk. Then 26-year-old lady who has undergone mechanical mitral valve replacement, so we have to expect that she is on warfarin, anticoagulant. Again, she is going to be in the high risk category. So the correct answer is 16-year-old previously healthy boy with a body weight of 40 kg. So that patient we cannot categorize as high risk. Then question number 4, what can be considered as an evidence of plasma leakage? Platelet count of 120, PCV of 50, ultrasound evidence of simple gallbladder wall edema, PCV 44 in a patient with baseline PCV of 36. So what are the evidence of plasma leakage? If a patient gets leaking, then patient will have pleural effusions and ascites, and PCV will go up. Like if it goes up about 20% above baseline, we consider it as leaking. Usually patients will enter into the critical phase when the platelet count drops below 100,000. And hyperproteinemia and hypercholesterolemia are again considered as features of leaking, but we don't do this as routine tests. So when we consider our answers, what can be considered as an evidence of plasma leakage? Platelet count 120 we don't consider as evidence of plasma leakage. It will drop more than less than 100,000. PCV 50 we can't consider as plasma leakage because we don't have any baseline PCV there. In some people PCV 50 may be his baseline. And ultrasound evidence of simple gallbladder wall edema, you can see it in just dengue fevers, so it's not considered as leaking. PCV 44 in patient with baseline PCV of 36, so 36 has gone up to 44, so there's 20% rise, so we have to consider that patient is as an evidence of leaking.
Yeah, I think as Madam said, when there's a 20% rise in PCV, especially if we are not in a good sophisticated hospital, if we just have a PCV machine, when the patient admitted, if we notice this, even maybe in the full blood count, or if you can do a capillary hematocrit, then we just can detect even without any sophisticated equipment. I think that is one important thing checking PCV.
Yes, the next question number 5. Which of the following features are not considered as dengue shock? Tachycardia in an afebrile patient, narrow pulse pressure, 20% rise of PCV, CRFT more than 2 seconds. So what are the features of shock in dengue? Sweating, the clinical features, sweating, severe abdominal pain and persistent vomiting due to gut ischemia because the blood will be diverted to the more important organs and the gut will be ischemic. Prolonged CRFT more than 2 seconds. Unexplained tachycardia, that means without fever tachycardia. Hypotension. Narrowing of pulse pressure 20 or less than 20, we consider it as compensated shock. Cold, clammy skin and restlessness. Unrecordable pulse and blood pressure, that we consider that is the profound shock. So when we take our answers, which of the following features are not considered as dengue shock? Tachycardia in an afebrile patient, yes, we can consider it as dengue shock. Narrow pulse pressure, yes, that is compensated shock. CRFT more than 2 seconds, again is shock. 20% rise in PCV means leaking. So usually we expect about 30% rise in PCV if patient is in shock due to leaking. And if the patient is in profound shock, there will be around 40% rise of PCV. So the correct answer is 20% rise of PCV, which indicate leaking but doesn't indicate shock. Question number 6. Which of the following cannot be considered as a symptom or a sign of dengue shock? Again, the same similar type of question. No clinical improvement with settling of fever. Severe abdominal pain with sweating, blood pressure drop of 130 by 90 to 100 by 80, cold clammy skin. So out of these 4 answers, as we discussed earlier, severe abdominal pain with sweating, feature of dengue shock. Blood pressure drop of 130 by 90 to 100 by 80. 100 by 80 means narrow pulse pressure, and the systolic pressure drop is also there 130 to 100. So it's again compensated shock. Cold clammy skin, shock, right? So no clinical improvement with settling of fever, that indicates patient has entered into the critical phase, but not it's not a sign of shock. So the correct answer will be no clinical improvement with settling of fever. Then the next question, a 45-year-old male patient admitted with 4 days fever, platelet count of 130,000 and PCV of 42. So day 4 fever, platelet count 130, PCV 42. So we can take this 42 as baseline PCV. Next day at 6 o'clock, his platelet count was 80,000 and 10 o'clock PCV was 47 and ultrasound scan shows PCF and mild ascites. So the PCV has gone up from 42 to 47. So at 10 o'clock, patient detected as having leaking, and 6 o'clock in the morning, platelet count has dropped below 100,000. So there's evidence of leaking there. Until that time, he was getting 100 ml of fluid per hour. How would you manage his fluid intake? Answers are increase fluid intake, decrease fluid intake, give dextran, give blood. So if we consider the dynamics of plasma leakage, usually the leaking will start slowly and it will increase gradually, and you will see the maximum leak during the peak, that's around 24 hours into the critical phase. Then it slows down gradually and it will stop altogether between 36 to 48 hours. So if we consider what happens, so what should we do? Like we usually give 1.5 to 2 ml per kg per hour during the febrile phase. And when we detect leaking, we have to increase the fluids gradually. Remember, we are not going to give boluses, we have to increase gradually. And during the peak of the leak, we have to give the maximum fluid intake, and then we have to cut down the fluids gradually. So the answer for this question is the increase in fluid rate because patient's PCV was rising and patient was leaking.
Yeah, I think that also that's a very good learning point, because even at maybe like if we don't know about how to increase fluid, sometimes I think we may just consider at that time we might give a bolus. Not, I mean, if you really don't know, because in that question that the vitals were stable but the PCV is rising. So the fluid should be just as Dr. Damayan said, gradually increased. Otherwise, if we give a bolus when we detect the rise in PCV, what will happen is when during the end of the critical phase, patient may get overloaded. That's, I think, sometimes that happens if you really don't know. That's a very good learning.
Next question, question number 8. 38-year-old male patient admitted with 4 days fever. Next day morning at 8 a.m., his platelet count was 98,000 and PCV was 40. At 4 p.m., his PCV was 46 and urine output reduced to 35 cc per hour. Ultrasound scan at 4 p.m. showed gallbladder wall edema, PCF and mild ascites. In this patient, when you take as the onset of the critical phase. Again, at 8 o'clock, platelet count 98,000 and PCV 40. Right? We can take it as the onset because it's just below 100,000. At 4 p.m., PCV has gone up to 46 and urine output reduced. At the same time, ultrasound scan showed leaking. So the answers are 8 to 12 hours before 4 p.m. From 4 p.m., that's the time of scan. And 24 hours before 4 p.m. and he's not in the critical phase. So the fourth answer is definitely wrong. He's in the critical phase. So again, when we discuss the dynamics of the plasma leakage around 8 o'clock, that's the day 5 of the illness, PCV 40, platelet count 98,000. And at 4 p.m. PCV is 46. So if we consider 8 now, the platelet count dropping below 100,000, the time platelet count dropping below 100,000, it will be around 8 o'clock in the morning, or a little bit earlier than that. So if we take it as the starting point, then the middle of the critical phase will be the 8 o'clock following day, and day 7, 8 o'clock, the critical phase will end. So the PCV is rising at 4 p.m. So we can consider 8 a.m. as the starting point of critical phase. And when we consider the leakage, ultrasound evidence of leakage, again there will be only mild ascites. So we can consider it as 8 to 12 hours before 4 p.m. Then the next question, 18-year-old previously healthy boy presented to the OPD with severe body aches and dizziness. He had fever for 4 days and afebrile for 1 day. Full blood count which was done on the day prior revealed platelet count of 110,000. As the medical officer OPD, what is the best next step you would take? Relieve him in the evening with repeat full blood count, admit immediately. Asked to take more fluids and relieve him with repeat full blood count on the following day. Prescribe paracetamol and dexamethasone and relieve him on the following day. So when we go back to the question, so this 18-year-old boy, he has a full blood count report which was done 1 day before, which showed the platelet count of 110,000. And he's coming on 4th day of the illness and he's afebrile for 1 day. So we have to consider patient is in critical phase, and as the patient is complaining of dizziness, we have to consider shock. So definitely this patient needs admission. So we have to admit this patient immediately.
That question also addresses the last stem, like prescribe paracetamol and dexamethasone. That's if you give in like a private practice, sometimes we have seen this sort of operation dexamethasone, because if you prescribe just for fever, I mean initially the patient may come like with even with the bleed, in fact, because so it should not be done.
So the question number 10, 28-year-old female patient presented with fever for 5 days and abdominal pain. On admission, she was afebrile, BP 80/60, CRFT more than 2 seconds and pulse rate was 124. So which means patient is in shock on admission. Her platelet count was 42,000 1 hour prior to admission, and on admission PCV was 52. So everything I think compatible with dengue shock. When do you take as the beginning of the critical phase? About 24 hours prior to admission, 12 hours before admission, on admission, 48 hours before admission. So again, when we talk about the dynamics of plasma leakage, if a patient is going into shock, it will be the peak of the leak. So if the patient is getting admitted, we'll say around 5 o'clock in the morning in shock, we have to consider at least 18 to 24 hours prior to admission as the onset of the leakage. So in this patient, we can take it as 24 hours prior to admission. So the next question, the same patient. So this patient presented with shock, and the patient's critical phase monitoring chart is shown. So according to this chart, we have taken the patient's 5 a.m. patient got admitted. So the first 24 hours not shown here because the patient was at home during that first 24 hours. And this is how we monitor, when we document the monitoring in a patient who is in shock. So we have to monitor them quite hourly. So the first 500 bolus we mark it like that, and second 500 bolus again we mark it like that. So for 5 a.m. to 6 a.m. we have given one fluid bolus, 6 a.m. to 7 a.m. again we have given another fluid bolus, that is 500 ml per hour. Then we have given another dextran from 7 a.m. to 8 a.m. Because even though we have given this amount of fluid, if you go through the pulse rate, still patients like pulse rate is coming down but still tachycardic. CRFT more than 2 seconds now is like equal to 2 seconds, but still patient is in shock. Blood pressure 80/60, 84/60, so 90/70, 90/70. So it has improved a bit, but still patient is in shock. And if you consider output, nil 20 cc, 35 cc, so the output is not that adequate. And if you see the PCV, 52 quite high, and it has dropped to 50, then again it has dropped to 50. So usually after fluid bolus, we expect PCV drop of 3, 4, 2, 3, 4 like that. So, and then as the PCV is high, we have given a dextran, and then after the dextran, PCV dropped to 35. So the maximum PCV drop due to dextran is 8 to 10. So if the PCV drop below 10, more than 10 points, we have to consider bleeding in this patient. So what we should have to do is, now the answers are gradually cut down to is reduce the fluid to 100 ml after the dextran, give a blood transfusion early, and give another dextran. So the indications for blood transfusion: hypotensive shock, that means if the blood pressure is dropping with normal or low PCV. Right? We expect around 30% rise of PCV if the patient is in shock. If we don't have that amount, that adequate PCV rise, and if the patient is in shock, we have to consider bleeding. And especially if the patient is complaining postural hypotension, dizziness and fainting. And reduction in PCV after fluid resuscitation without clinical improvement. That means if the patient is still having unstable vital signs and we are giving fluids, and PCV has dropped, but the clinical there's no improvement, vitals no improvement. Again, we have to give a blood. And if the patient is having frank bleeding, if we can see the bleed, if patient has bled around 6 to 8 ml per kg, even though the PCVs are normal, even though the vitals are normal, we have to give a blood. And hematocrit drop of more than 10 points after dextran bolus. And the maximum drop we can expect is the 10. If the patient's PCV drop more than 10 points, again we have to consider blood transfusion. So in this patient, the correct answer, as the PCV dropped from 50 to 35, 15 drop, we have to give a blood. And in addition, patient was not that stable. If we go back to the chart, the PCV drop 50 to 35, that means 15 drop. Still the CRFT around 2 seconds. Still the pulse rate is not normal. BP again 95, 70. Pulse pressure of 25. Output is not that good. So we have to consider blood here.
In that case, in that chart, this is just a simple thing. If we don't do PCV prior and after the exam, then the decision about this giving blood, that sometimes it will be difficult. You may just consider there's some the parameters are not very stable, but if you just without PCV you see there's some improvement of heart rate, then the urine output also somewhat improved. So the main decision that doing a PCV even after a bolus of dextran, that's very important in deciding the type of fluid to be given.
And sometimes we can't decide on whether to give a blood or not, so we give a dextran and see how much PCV comes down. Then after that it is easy for us to give a dextran, give a blood. So the question number 12, 22-year-old male admitted with fever for 3 days with a positive NS1 antigen. His platelet count was 122,000 and PCV was 40, so we can take it as the baseline. He was started on febrile phase monitoring. Next day at 8 a.m., full blood count, short platelet count of 80,000 and PCV of 42. So the PCV has gone up a bit, 40 to 42, and platelet count has dropped down from 122 to 80,000. His urine output was gradually dropping, and at 2 p.m. PCV was 46. So at 2 p.m. PCV has gone up to 46. At that time, urine output was 0.5 ml per kg per hour for the last 2 hours. So urine output has dropped. All his vital parameters were normal. Ultrasound scan was not done due to technical fault. What would be the next best management step? Start the critical phase monitoring chart and view fluid at a higher rate. Start critical phase monitoring chart and give a crystalloid bolus of 500. Start critical phase monitoring chart and give a small dose of IV furosemide. Monitor the patient on febrile phase monitoring chart until the ultrasound scan is available. So, if we take these counts and the parameters, so the platelet count day 3, platelet count 120,000, PCV 40, all the vitals normal. Day 4, morning 8 o'clock, 80,000 platelet with a PCV of 42. If you see, even though all the parameters are normal, 40 has gone up to 42, 122,000 has dropped down to 80, below 100,000. So we can expect that the patient has started leaking now. And at 2 p.m., 42 PCV has gone up to 46. All the vitals are normal, and but the urine output has dropped to 0.5. So even though we don't have any ultrasound scan, we know that the patient is leaking. So we have to start the patient in the critical phase monitoring, and we have to increase the fluid because PCV is rising and the output is dropping. And at this point, we don't need any bolus as the patient is not in shock, so we don't need any bolus. We can give a higher rate of fluid. The most important thing, should not give any furosemide because patient is in the going towards the peak of the leak. If you give furosemide, you can you can decrease the intravascular volume, and then patient will end up in shock. And we have seen a lot of patients are like waiting in the critical febrile phase until the scan is available. That's not correct, because even though we don't have the scan, we know that the patient is leaking, so we can take the patient to the chart.
This case also in a peripheral setting, like when you don't have ultrasound scan and other facilities. So what we can do, especially the monitoring, the pre-critical chart monitoring is very important. But even without ultrasound scan, when the platelet count is dropping and when the fever is settling and the PCV, there's a gradual rise of PCV, that we need to monitor the patient, take the patient into a critical phase monitoring. That emphasizes this case even if you don't have proper facilities. Then we can monitor it very frequently, like maybe 3 hourly, and then we can manage sometimes even without, if you don't have scan.
Next question. 40-year-old lady admitted with fever for 5 days and positive NS1 antigen. On admission at 8 p.m., her platelet count was 60,000 with a PCV of 42. The ultrasound scan shows evidence of leaking. So on admission, she is leaking. 2 days prior to the admission, her full blood count showed a PCV of 38. So we can, and the platelet count of 196,000. So we can take 38 as the baseline. So on admission, the platelet count has dropped down to 60 with the PCV of 42. So we can take it as patient is leaking on admission. Next day morning, her BP was 90/70 and the pulse rate was 100. So patient was in compensated shock next day morning. PCV at the time was 47. So PCV has gone up. Since admission, she had been given 3,200 ml of total fluids due to marginal urine output. What would be the best next course of action? So in this patient was in the hospital on admission leaking, so patient was given IV fluids and total fluid 3,200 given. And now the patient is in the peak of the leak with high PCV. Now what are you going to do? Crystalloid 500 ml bolus over 1 hour, dextran 500 ml over 1 hour, dextran 250 ml over 1 hour, red cell concentrate transfusion. So actually in this patient the answer will be the dextran, because the 3,200, so that means out of 4,600 more than 2/3 given, and patient is in shock. If we give too much of fluid again, then the problem of fluid overload comes. So here, of course, as we have given adequate amount of fluid, we can give dextran. So the indications for dextran fluid overload: shock with high PCV after crystalloid boluses, and persistently high PCV with nearly any fluid quota. So the correct answer, dextran 500 over 1 hour. The next question, a 55-year-old female who was managed for dengue fever was transferred to a hospital due to ongoing hematuria. So this patient is having hematuria. Before transfer, she was given 6 units of platelet when the platelet count was 12,000. As the platelet count was 12,000, somebody has given a lot of 6 units of platelets on the previous day. Post-transfusion platelet count was 26,000. However, on the day of transfer, morning platelet count has dropped down to 12,000. So the platelet count was 12,000 and patient was having hematuria. On the day of transfer, she had no fever and the vitals were all normal. So, hemodynamically stable patient with 12,000 PCV, 12,000 platelet count, and having hematuria, and ultrasound scan showed no leaking. So PCV on admission to a hospital was 31 and the baseline was 38. So definitely there's a big PCV drop, and the blood gas showed pH 7.4 is normal with a lactate of 5. So in dengue patient, lactate levels should be monitored if there's any problem. So high lactate indicates there's a problem. So what should you do? So in this patient, PCV has dropped down from 38 to 31. So the answers: another platelet transfusion, red cell concentrate transfusion, sodium bicarbonate, FFP transfusion. So the answer should be the red cell concentrate transfusion. Sodium bicarbonate is not needed because patient is not acidotic. FFP no use. Even though you give platelet, platelet will not improve because again platelet count will drop. Naturally platelet count will increase the following day.
Yeah, the main thing is that PC has dropped below the baseline. So not the platelets that we need to give a blood transfusion because platelets have a very short half-life. So this is, I think, important learning point.
The question number 15, which of the following is not considered as a feature of convalescence phase? Diuresis, bradycardia, itching of the palms and soles, rise in PCV. So the features of convalescence phase: improved general well-being and appetite. Patients, the ill patient will get up and then patient will ask for food as well. Convalescent rash will appear, that is the red, like completely red rash, like a beetroot. Generalized itching more in palms and soles, that is again a common complaint. Hemodynamically patient will become stable, bradycardic, and patient will pass a lot of urine because reabsorption will be taking place at that point. PCV will become stable when it will drop down, and WBC will go up and the platelet will go up. So the correct answer is the rise in PCV. Diuresis, bradycardia, and itching of the palms and soles are features of convalescent phase. Rise in PCV is a feature of critical phase. Last question, which of the following is true? All the patients who have a platelet count below 100,000 should be monitored as in critical phase. That is not necessary. Only the patients who are leaking should be monitored in the critical phase. Platelet count should be monitored at least 6 hours. Again, is not needed. We have to do a platelet count at least once a day. If we can do twice a day, it's better. In the absence of ultrasound scan facilities, patients should be transferred to a place where they are available. That is again not necessary. Ultrasound is not necessary to detect leaking. If we have the PCV, we can PCV and clinically we urine output, vitals, we can diagnose leaking. In refractory dengue shock, calcium level should be corrected. That is correct. Because in refractory dengue shock, ABCS to be corrected. A means acidosis, B means bleeding, C calcium, and S sugar. So the last answer, the calcium level should be corrected. That's the correct answer. So that's the end of our questions and answers. So hope you enjoyed the quiz. So thank you very much for listening.
Thank you very much.
Thank you very much, Dr. Damayanti Dambitiya and Dr. Sushant Asirya and Dr. Tisara Pereira for a very interactive session. He has a vast experience in clinical management of dengue and currently responsible for drafting the guideline for dengue death reviews. Over to you, sir, to discuss the lessons learned from dengue case reviews. Thank you.
I wish to thank Sri Lanka Medical Association for giving this opportunity. Thank you, Anuja, for the kind introduction. So what the task before me is, I have been given the task to analyze the deaths in 2022. So we are in the process of analyzing all these deaths. I just want to highlight the points that we need to address in order to prevent the same thing happening in the future. So it's not an easy task because some of the things are pretty obvious and some of the things are not pretty obvious. So we will skip these slides, but this has been addressed. So as you can see, when you sort of trying to develop something new, like to review formats, there are standard formats already in place. There are a few things in Ministry of Health, like maternal death reviews, then fetal-infant death reviews, all are in place at the moment and going on for a few years now. But on the other hand, when you see outside Sri Lanka, outside Sri Lanka, this has been going on confidential inquiry principles and trying to implement the issues detected. Recently, the confidential inquiries in the United Kingdom has been replaced by patient safety incidents. It's a big document. And it's a comprehensive document. All these things are in place to detect any issues and to rectify whatever the pitfalls or whatever the deficiencies in the system. So when we try to analyze our cases, what we found was there are two things. One is when a patient developed dengue, they are initially managed in the community. So as Dr. Anand highlighted previously, there are issues that happened in the community which has adverse events. So the issues that happens in the community that we have sort of identified so far was delay in suspecting the dengue on clinical grounds. And sometimes the patient was seen by a doctor and not ordered a blood count. And so that and some of them, some of the physicians in the community has done medicine, which is quite good, so which means that the dengue is confirmed. And also some of these patients have been sort of having other issues like with dengue, like vomiting in the community, and they're presented with dehydration. And some of these unwantedly prescribed the drugs like steroids and non-steroidal antivirals, which adversely affect the outcome of these patients. So in the community, some of these patients have not gone to a doctor, and some of them have gone to an MBBS doctor. And whether these doctors have given or told them what the warning signs are, and they need to come back if they develop warning signs are also a question. And then whether the patients have been recommended on the admission on time, because we still see sometimes there are late admissions, and some of these patients have not been to a doctor in the community, but they get admitted fairly late and causing a lot of issues in the clinical issues in the hospital. And also this is another issue that we see had been overlooked by the community physicians. The physicians or doctors in the community, like general practitioners, not taking into consideration of the comorbid factors and the high-risk factors. This is again the point was highlighted by previous way Dr. Anand. So I need to identify whether this particular patient has comorbid factors and or high-risk factors which need to be considered very seriously if they are suspecting of dengue in the community. Again, this is another important thing. Again, this is highlighted by Dr. Anand. The patient who actually is a resident of very low prevalent areas like in Monoragala and come to Colombo and do some job here in Colombo and get dengue here, and then they go back to Monoragala and get admitted to Monoragala hospital with dengue, and if he dies over there, then probably he contracted dengue from Colombo, not from Monoragala. So it's important that we need to identify their movements, their travel, so that preventive healthcare people can investigate because issues. If they investigate in Monoragala, I think there was no dengue there, but probably dengue was contracted in Colombo. So we need to find out where he was working for the previous 2 weeks. Then, even at the hospital, there are lapses. So what we identified in the lapses in the hospitals were delay in admission to hospital, as I said before. Then lapses in monitoring of febrile phase, before leaking, prior to leaking. Because if you manage that febrile phase or before leaking or during leaking without leaking, then they can prevent any unpleasant outcomes. And sometimes a delay in confirm the diagnosis and delay in identifying leaking. Because when you monitor, you clearly find that the patient is leaking, but some of them have not identified this patient is as leaking. And also delay in identifying impending shock, when the parameters are suggestive of shock that have not been identified by the doctors. Then delay in starting critical monitoring chart, because we normally have 2 charts. One is febrile monitoring chart and another one is critical monitoring chart. So the critical monitoring chart should be started the moment you realize that the patient is leaking. Then we can't actually interpret the signs and cause clinical decisions. Then poor monitoring of clinical parameters, especially the machine numbers, because Dr. Anand again said very clearly, things like blood pressure, if you go by the machine readings, you can get, you are not going to get a true vital assessment of the patient, because we know that the machine, when you do it on the machine, when you assess the machine in low perfusion state, the machine numbers are not very accurate. So always it's better to assess clinically, which is highly reliable. This is another issue that we observed. One is the actual body weight versus ideal body weight. And sometimes the weight used for fluid calculations are totally different from the actual body weight and the sometimes the ideal body weight. Because all these parameters ultimately depends on the weight used for calculations. At the hospital, again, the issues are the fluid calculation may be wrong, and cumulative fluid is not documented, and some charts, only the IV fluids are documented, not the oral fluids. And then when we calculate the cumulative fluids, sometimes the oral fluids are not taken into consideration. So therefore, all these fluids need to be documented very clearly on the charts in order to have an idea about how much fluid is being given to these patients. Then, as I said before, the issues are there are lapses during the febrile phase management, like non-shock patients. And in the patients who are having impending shock, there are management issues. And also the shock patients, there are management issues. And also the failure to identify recovery and then try to fine-tune the management is another issue. So what we have observed during the hospital stay was not matching the leak with the crystalloid infusions in non-shock patients. If you don't fine-tune the crystalloid infusions and not matching the leak, again can cause problems. If you sort of give too much of fluids, can cause fluid overload, and if you don't give too much of fluid, that patient might, then they start leaking, might go into shock. And the other important thing is when the patient develops shock or embedded in shock, delaying adequate resuscitation within the first 2 hours of leaking is another big issue, because the moment you identify that there is a leak or the impending shock, that the patient should be stabilized within as soon as possible. Because again, it sort of leave it more than 4 hours that causes that can contribute to unpleasant situations. Then things like colloid, dextrans, not given when required, is another issue that is happening in the hospitals. So in the chart, the current chart we use in the hospitals in dengue monitoring, unfortunately, the pulse, there's no column for pulse volume, so that all the parameters are there. I think basically machine-read parameters, we use the machines, and not clinical, not clinical parameters, pure clinical parameters. So pulse volume is, you can't document pulse without examining the patient, just feeling the pulse. So pulse volume is really important in this chart monitoring these patients. And whether the peripheries are cold or not, or then clammy, and we call it a cold line. So if there is a cold, then that means that the patient is in shock. So, and also, as I said before, manual blood pressure, because we see almost all these charts, the blood pressure gives something, not round figures, they give 123 upon 97, something like that. We know that those are all matching rate, not by auscultation. If you have auscultation, we give a round figure. Then the urine output is documented but not calculated according to the time, like urine output for ml per kilogram per hour. So this is another issue that we tend to overlook the management. Then the amount of the fluid given over cumulative fluid or the target fluid is another. So all these things should be done by should be a clinical assessment and documented. Then only we can make an accurate assessment of the patient, so that pick up early leakers and patients who are going into shock early and then corrected proactively. So apart from the knowledge and the skills in managing these patients, there is a big component in soft skills, like in managing this type of patients. What we mean by soft skills is non-technical skills. So what comes under this is poor decision making by the first responder or the middle grade person who sees this patient during 24 hours, day and night. Then sometimes it's due to the poor communication of the decisions among the house officers, SHOs, and the consultants. This is another issue that we have seen. And another issue is the failure to ask for expert help from a colleague during critical phase. And very often we have seen that some of them actually sought expert help after 48 hours of critical phase, which is of no use. And also the poor documentation. And the important thing is failure to identify the end of leaking and continue to IV fluids and push them to fluid overload and heart failure, which also can cause issues, clinical issues. Then complications. The lapses in complications. Complications are when the patient is not being corrected, the shock is not being corrected. They can end up with acidosis, which might not be recognized. Then there might be delay in identifying concealed bleeding and giving early blood transfusion is another issue. and delay in correcting calcium, and delay in correcting sodium and sugar. And the patient is recovering if you don't stop, and they can go into fluid overload and cause problems. And as previously mentioned, identifying liver failure early and correcting and giving supportive care for the liver failure is also important. And the last one is actually it's another issue that has been there for it has been addressed pretty well in some places now. Delay in recognizing HLH, that is hemophagocytic lymphohistiocytosis. So if you don't recognize that and treat it adequately, these patients can end up with unfortunate incidents. So these dengue patients, although there are facilities in their respective hospitals, sometimes they tend to transfer this patient from one hospital to another hospital. So during the transfer, there are issues that we notice. One is the reason for transfer, it's not very clear. Sometimes maybe unstable patients. Sometimes the patients are transferred with inadequate amount of fluid or not fluid at all. And some of the patients not accompanied by the doctor. And also the patients are transferred only with the transfer form and not with the referral letter to stating what was given there and what are the condition and the duration of the critical phase. So even at the hospital, there are issues like sometimes there has been a very delay in initial examination by the house officer for some reason or other, or the medical officer, delay in initial examination by the middle grade officer, and delay in initial examination by the consultant. So these things are also plays an important role. So the cause of death, finally. So the cause of death documented in the notes is very often says a patient died of dengue shock syndrome. That is as simple as that. But you need to elaborate a little more detail if you want to get into the exact problems. Like finally, the patient died of dengue fever or dengue hemorrhage fever. Why we put dengue fever? But dengue fever also can cause death if they develop HLH syndrome. Then the dengue fever also can cause bleeding and may cause death. And also they should document whether it was due to too much of fluids causing heart failure or pulmonary edema, or the death was due to too little fluid, given too little fluid or underperfused critical phase and causing organ damage, and what type of organ damage? Renal, liver, renal, respiratory encephalopathy, and electrolyte issues, and also metabolic complications. So unless you write down and put down the cause of death or death details like this, it's very difficult to find out what has happened. So after death, they are supposed to have an institutional death review. So institutional death review should be held without any delays. Sometimes we find that it has been held many months after the death. When everybody has forgotten about the patient. But if you have it a bit early, then you can probably recollect what has gone wrong, even if it's not documented, and try to identify the areas that needs improvement. So finally, what we need, the objective of this type of death reviews is to not to find fault with the individuals, like a fault finding, but to identify the issues that actually will be recommended for the system care in the future, so that the same mistakes shouldn't happen in that institution, and you can cut down bring down the current death rate to a significant level, so which will take little time. So this is the end of the presentation. I would like to thank the director of the National Dengue Control Unit, and Dr. Jagat Amasekara and Dr. Jayanth Kiraman, who contributed a lot with the consultant doing the death audits before me, and MOH in the dengue unit, Harshini and Chanaka. Right. Thank you very much.
Thank you very much, sir. And you have given a very important, you have highlighted very important points to improve in dengue management. Thank you so much.
Thank you, madam. This concludes our specialist sessions. But we have received several important questions from the audience, both from online as well as physical. So I would like to invite all the resource persons to the head table. Sir. So there's a question from one participant. What is the fluid therapy in pregnancy, diabetic patient, and an obese patient with weight above the ideal body weight?
Thank you for the question, because that's a very important question, and a lot of people have a dilemma on fluid therapy, those categories. Basically, they stick to the same fluid regime. In pregnancy also it's the same fluid regime. We are not giving any additional fluid. However, one has to remember that pregnant mothers can get complications commonly. It's more common than in others, and also their leaking tend to occur earlier than other people. So we need to monitor those patients, pregnant mothers with dengue. When the platelet count goes, what is recommended is when the platelet count goes below 150,000, start monitoring. So they can get leaking before other people. Whether it is obese, whether the weight is 80 kilos or 60 kilos, we give the same fluid regime, and we haven't had any problems. However, in diabetes, if the output is significantly high, then we may have to think of giving additional fluid to compensate that loss if it is excessively high, if the output is excessively high. Otherwise, it's the same fluid regime. When they are leaking, you increase the fluid. In the critical phase, latter part of the critical phase, we cut down the fluid regime.
And the output, of course, we have to maintain a little bit higher than normal, what we say 0.5 to 1. So we expect a little bit higher than 0.5, at least 0.75 per hour for a pregnant woman.
Thank you, madam. There's another question for patient being managed in the community. If patient is okay and the platelet count is above 100,000, can we monitor the full blood count once daily? Is it advisable to do it twice daily? Does this depend on whether they are febrile or not? Platelet count is 100,000.
Yeah, usually we admit when the platelet count comes below 130,000, because after 130,000 we have to monitor the patient in the hospital. So if the patient's platelet count is above 130,000, we can we can send the patient home. But still, then we have to teach them about the warning signs. There is something called warning signs in dengue. So abdominal pain, no clinical improvement with settling of fever, persistent vomiting, reduced urine output, dizziness, bleeding. So those are the warning signs. If patient has at least one of warning signs, then patient needs to get admitted. Can't wait till next day to see the report. So if patient doesn't have any warning signs and patient's platelet count is around more than 130,000, then we can wait for the and patient's clinically all right, then we can do the count following day.
Just to add a little to that, in the general practice or at the OPD, you have to think when you see a blood report of a patient when the blood count was done. You may see a patient in the evening where the blood count was done in the evening. So if the patient comes with a platelet count of 144,000, which was done in the morning, and you see the patient in the evening, obviously the blood count, platelet count would be much less than that by that time. So either you repeat a count then and there, or obviously would be to admit the patient. So consider the previous count and also when the count was done when you see the patient. The doing blood counts does not depend on the presence of fever. Because in some, generally the fever will tend to go on for 5 days, but in some people it tend to resolve within 2-3 days. Still, it's important to do regular blood counts daily, and if necessary, if the count is dropping rapidly, if the patient can have easy access, you can do it twice a day. If the platelet count is getting close, going below 160,000-50,000, you can do twice a day and decide on admission depending on that. So even the platelet counts tend to drop generally for about 6 days and maybe for 7 days, and then generally it starts to go up. So until that time, the platelet count should be monitored.
Thank you, sir. There's another question. Do we have to withhold antiplatelet and anticoagulant drugs in a patient with dengue fever, and when?
And
when we have to withhold?
Yes, we have to withhold antiplatelet and anticoagulants when we diagnose dengue because platelet count can fall very rapidly. And even if we stop antiplatelet, the effect will last for about 1 week. So usually nothing will happen to the patient. So we can stop it, and once the platelet goes up, we can reintroduce it.
There's another question. Could you please highlight the key points in the primary care setting? We need to look at the referral of the patient early to the hospital for a patient who have confirmed to have dengue. Referral from a primary care setting, sir. What are the key points?
Again, it depends on the vital parameters as well as the warning signs and the platelet count. So if the platelet count comes below 130, definitely patient needs admission. And if patient is having any warning signs, again, even though the counts are higher than that, patient needs admission. And if the vitals are abnormal or patients having some dizziness, fainting, and those symptoms, again, patient needs admission.
As Madam said, apart from that, I think having a risk factors, and if the patient is having difficult access to the any good hospital, that also we have to consider, I think, that's it.
If the patient's day 5 blood reports show dengue weakly reactive for IgM antibodies, NS1 negative on day 3, is that counted as an active infection?
I think for the purpose of management of these patients, the most important investigation is the blood count. I would say the single most important investigation is the full blood count. So whether the patient is having antibody positive or not, especially in day 5, IgM, mild or faintly positive IgM, may be an acute infection, or it may be showing an old infection, but in old infection generally IgG is positive. So if the only IgM is positive, it is more likely an acute infection, but whether it is negative or positive does not matter actually. The admission, monitoring, all those decisions are taken based on the full blood count. I think therefore, rather than wasting money on doing antibodies, do the full blood count daily, and then because the decisions are based on that.
Thank you.
Even the antigen, if you are doing antigen, do it within first 3 days, because the chances of getting a positive report is high within those 3 days. But again, in about 30% of cases, antigen can be negative. So therefore, once again, the important investigation is the full blood count. Even if the antigen is positive in Sri Lanka, we consider it as dengue, because other flaviviral infections where it is positive are very uncommon in Sri Lanka. But even if it is negative, still if the clinical features are symptoms, signs are suggestive of dengue, do the full blood count and follow up with full blood counts. That is what is important.
There's another question, sir. If we are close to exceeding the fluid quota in critical stage, is there a place for dextran half boluses instead of dextran full bolus?
Yeah, dextran is necessary if towards the latter part of the critical phase, if the patient is unstable with high PCV. So we prefer to give the full bolus first, and then later, if necessary, if the patient needs further boluses, then we may give half boluses. But as the first one, I think it's better to give the full bolus. And of course, if the patient is stable, we can reduce the fluid in the latter part of the critical phase and see. But if the patient is unstable with high PCV, a full bolus of dextran.
That's another question. We had a NS1 positive patient who had significant hypotension on day 1 with platelet count 150,000. No evidence of leaking or bleeding. Responded with fluid bolus. What is this condition? She has asked.
It's not uncommon to see patients presenting like that. And the most likely reason in that instance is the dehydration. And also, one has to remember with high fever, there can be significant vasodilatation leading to hypotension. So, and generally these people can't eat and drink, and sometimes people tend to have vomiting and loose motion. And occasionally we had patients with severe loose motion getting admitted with hypotension, and initially the main reason was the dehydration in these patients. So we need to hydrate. That can happen even in the first 2-3 days. So even though we say the admission has to depend on the admission is decided by the full blood count, we have to consider other parameters also. Even if the count is normal, if the patient is hemodynamically unstable, of course, then we have to admit and treat. So the reason for initial shock in a dengue patient, the main reasons for the shock is the bleeding or leaking and bleeding both. But in addition, especially during the early part of illness, the dehydration can be the reason for the shock.
Thank you, sir. If the physical audience have any questions, you can raise the questions now.
Yeah, the question is that there was a child who had shown evidence of leaking ultrasonically, and the platelet count was 180,000. Yes, now even though we say the leaking occurs when the count is less than 100,000, that is the, I think in probably 99% of instances that is the case. There can be occasional case, rare case, where leaking occurs early. I think for the last 12 years, I have seen maybe 5 patients who have leaked when the count is above 100,000. So it is very rare, but occasionally it can. But then we can't recommend admissions on such patients, such counts, considering the rarest possibility. But then if the patients are unstable, that can happen. Another thing we can see, especially in young females, is that they can have little bit of pelvic fluid in an ultrasound examination which is normal. It can be related to their menstruation and things. But then they won't have this classical gallbladder wall edema. So in such patients, we can repeat the scans and see whether they are developing actual dengue leaking rather than this physiological fluid in the peritoneal cavity.
Any more questions?
Usually, if the patient's platelet count is 130, then you have to admit. And if it's more than 130, and if patient is quite all right, we can like if there's no rapid drop of platelets, then of course we can ask the patient to go home and come back. Sometimes even though the platelet count is 200,000, we can see the next day count 60,000 and patient is leaking. So if a rapid drop is there, then of course we have to admit. And if the patient is bleeding, yes, you have to admit. If patient is bleeding, I think you have to admit, even though the counts are high.
When to repeat the count depends on, I think, the previous count and also the duration of the illness. If they come on day 1 with the full blood count, full blood count showing platelet count of 200,000, of course we can repeat it next day evening, maybe even 36 hours later. But if they come with that on day 3 or 4, where the counts tend to drop rapidly, then better to repeat it 24 hours later if the count is high. But if they come with a count of 160, 150,000, best thing is to repeat it after 12 hours if it is possible.
Thank you very much. So I think due to time constraints, we have to limit some of the questions. Thank you very much. I think we had a very successful workshop today. So to conclude the session, I would like to invite Dr. Sajid Edirasinghe, Secretary, Sri Lanka Medical Association, to give the vote of thanks.
Right. Good afternoon, everyone. Thank you very much for joining with this regional clinical meeting in the SLMA in collaboration with the IDH Hospital and the Dengue Control Unit of the Ministry of Health. So I personally would like to thank Lahiru for taking so much of effort of organizing this event especially with currently emerging topic, the dengue, to update their knowledge. I especially thank the Dengue Control Unit of the Ministry of Health as well as for the IDH Hospital for agreeing to collaborate with the Sri Lanka Medical Association to conduct this session. And also I would like to thank the IDH Hospital and the staff for their warm hospitality provided towards the SLMA. And as Dr. Vinyareratne mentioned in the morning, so the main basic idea of these regional clinical meetings is to disseminate the knowledge. This is something off the record. As you all know, with this current crisis situation, there is a certain percentage of brain drainage out of our country. So this is these type of regional clinical meetings are important to educate, because we are reducing the human resources because of the brain drainage, and whoever is existing in this country will have little bit of overload of work, and they especially they will not find enough time to update their knowledge. So these type of regional meetings are very important to update our health staff, medical as well as our paramedical staff about the current context and the recent updates. So please join with Sri Lanka Medical Association for future events as well. And the next regional clinical meeting will be in collaboration with College of Military Medicine in Trinco. So we will be, because we will be going all around the country, because last 2 years we couldn't do it because of the COVID restrictions and the fuel crisis and all things. Now this time in this year, 2023, we are planning to go around the country and disseminate the knowledge, because whoever who wants to contact and collaborate with Sri Lanka Medical Association are warmly welcome. So we are very happy to collaborate with any college, any association, any club, any hospital, any clinical society, and our main target is to disseminate the knowledge. So to educate our medical as well as our paramedical colleagues. So thank you very much for joining with us today, and have a pleasant evening. Thank you.
Thank you very much, Dr. Sajid. Before concluding, I would like to invite Dr. Lushan Jayasuriya, Senior Consultant, to deliver the certificate of acknowledgement for all the resource persons. Sir. Dr. Anand Vijay Vikram. Dr. Damayanti Idampiti. Dr. Srilal De Silva. Dr. Susanta Asiri. Dr. Tisar Pereira. Dr. Jagat Amarasekar. Thank you, sir. Thank you. Thank you very much, everyone, both physical and also online participants. I think we had around 200 online participants as well. Very active participation. Thank you very much for all your encouraging words and for being there till the end of this successful workshop. We will meet you again. Thank you very much. And lunch is served in the cafeteria for the physical participants. Thank you.